and sideline hepatitis and STDs, leading to chronic capacity disparities by infectious disease portfolio at health departments. We often see cutting-edge initiatives being proposed and funded in the HIV space, and if we're lucky, then hepatitis gets to be integrated into that programming. But with much less funding and often with a lack of clarity that makes it challenging for hepatitis providers to actually integrate those services endemically. Additionally, many jurisdictions have not been able to develop the disease surveillance and data infrastructure that's required to be able to build out robust and accurate hepatitis epidemiological data and ultimately to implement viral elimination plans. This disproportionate investment in the nation's hepatitis infrastructure when compared to the public health threat of viral hepatitis, including disease mortality, costs to the health system, and inequities in access to care and treatment, is a public health failure. The long-standing underfunding has resulted in a national hepatitis landscape that is very uneven and state-driven, and generally speaking, is unable to respond to the burgeoning hepatitis epidemic that has seen skyrocketing rates of viral hepatitis transmission in the past few years. But we have the biomedical tools to prevent new Hep A and B infections and to cure Hep C. So really the crisis that we're facing ultimately hinges upon the nation's healthcare policies and spending priorities that sideline investments in public health and perpetuate fragmented health systems with persistent workforce challenges that are unable to grapple with the full severity of rising rates of Hep A, B, and C that are resulting from the substance use and overdose crisis. The extent of these underinvestments became very apparent during the COVID-19 pandemic. The novel coronavirus strained every aspect of our health system, compounding the long-standing challenges that hepatitis programs faced. The hepatitis staff that already split their time among disease portfolios were suddenly detailed to the COVID response, halting most, if not all, hepatitis programming in many jurisdictions. In 2020, in collaboration with NVHR, HEP, NASTAD, Hep B United, Hepatitis B Foundation, and NACHO, HepView created a fact sheet outlining the impact of the pandemic on viral hepatitis providers and the experiences of clinical providers, community-based organizations, and health departments during COVID-19. In 2020, 76% of jurisdictions reported that hepatitis staff had been detailed to the COVID response, further limiting capacity to provide hepatitis services. And 93% of hepatitis programs faced a reduction in outreach, education, testing, and linkage services. A breakdown of that is included in the chart on the slide. I know it's a little bit blurry, and sorry about that. The limitations caused by the COVID pandemic compounded those challenges that hepatitis programs already faced and really elevated a new urgency for Congress and the administration to finally prioritize hepatitis programs in the face of the twin crises of the pandemic and the substance use and overdose deaths. Ultimately, the pandemic laid bare the cracks in our public health system and revealed the limitations of our country's vaccine infrastructure, our public health workforce, and our health data systems and disease surveillance and intervention networks. As we continue to respond to the COVID pandemic and assess what did and didn't work over the past 2 years, many policymakers are eager to build off of the lessons learned and to strengthen the public health system to prevent future crises from leveling our health system when it's most needed. And despite the vitriol and politicization of public health that we're increasingly experiencing, the pandemic did create a political environment where policymakers are increasingly concerned with developing that strong public health workforce, bolstering adult vaccination, and addressing health disparities. The environment is ripe for hepatitis advocates to call on Congress and the Biden-Harris administration to take meaningful actions to improve hepatitis programs, ranging from things like locking in telehealth flexibilities that were afforded by the Public Health Emergency Declaration, advocating for the integration of hepatitis services and mental health and substance use legislation, supporting harm reduction providers, and scaling up community-based drug user health programs to intervene on the key driver of hepatitis transmission and link people to care, reducing barriers for hepatitis diagnostics to come to market, defending drug pricing programs that provide safety net coverage of expensive medications like the 340B drug pricing program, And finally, for Congress to take bold steps to rectify the chronic underfunding of hepatitis programs. And HAP is working to do just that. We meet once a month or more to coordinate on an advocacy strategy to secure public funding for hepatitis programs and work to facilitate regulatory policy changes at the federal level and advocate for legislation that supports our public health goals. HAP members work closely together in coalition to set our strategy and conduct the advocacy and policy work. We strive to achieve decision-making on a consensus basis when possible and align our messaging and priorities with each other to make sure that we build a chorus of voices that are all calling for a greater focus and resources for hepatitis programs. Listed on this slide are a few of the organizations that are heavily engaged in HAP's work, but it's far from a comprehensive list of organizations. HAP was created to address the long-standing underfunding of hepatitis programs. It was first formed in 2004 as the Hepatitis C Appropriations Partnership, or HCAP, and then renamed to the Hepatitis Appropriations Partnership in 2010. NASTAD founded HAP, and we're responsible for convening the coalition and facilitating the coalition's workflows, even though we all pitch in a bit into the final products of the coalition. We convene the national and local hepatitis and HIV organizations, public health and provider associations, community-based organizations, and other key stakeholders to collectively impact policy change. As reflected in the name change in 2010, HAP's priorities and goals have grown over the years, and the coalition doesn't just engage in appropriations advocacy. HAP engages 3 key advocacy pathways to enact policy change. The first and primary goal of the coalition is in the name. We advocate on the Hill to secure more funding for viral hepatitis programs. We coordinate a legislative strategy to educate Hill staffers on the hepatitis epidemic, to request more funding for viral hepatitis programs, and to advocate for legislation that improves public health and increases providers' ability to deliver hepatitis services. Secondly, we leverage an administrative strategy to secure policy change through the administration's federal agencies and operating divisions. We meet with key health officials at HHS and CDC to advocate on behalf of hepatitis programs and to elevate the hepatitis disease portfolio within syndemic approaches at the NCHHSTP. We also submit public comments on the agency's rulemaking to make sure that our policy priorities and perspectives are reflected in the final regulations and guidance. And finally, we engage key stakeholders within the executive branch to secure support for hepatitis within the administration's broader coordinating forces, such as the White House Office of Management and Budget and the Office of the President, which, for example, issued a presidential proclamation on National Hepatitis Testing Day last year. All of these advocacy pathways support the work of each other, and by pulling on each lever, HAP works to build an environment where hepatitis is prioritized in the government's spending and health policymaking. Next, let's dig deeper into these policy levers, starting with the budget and congressional appropriations process. Each year, Congress passes an appropriations bill that funds federal agencies and programs for the upcoming fiscal year via that budget and appropriations process. During the appropriate cycle, lawmakers negotiate on funding levels and spending priorities, working to achieve a bipartisan spending legislation that can secure majority support in both the House and the House of Representatives and the Senate. Landing on a bipartisan agreement is challenging, especially given the partisan rancor that is a hallmark of the modern political environment, but it's of critical importance given that the yearly spending bill is a must-pass legislation. And what do I mean by must-pass? Without an agreement on the appropriations bill, federal funding will lapse, leading to a government shutdown. Because of this, the appropriations process often involves high-stakes negotiations around spending priorities, and in more recent years, as it has become all too familiar with shutdown threats. If no agreement is reached, Congress can issue a continuing resolution or a CR that extends the current fiscal year's funding through an agreed upon date, by which Congress must then issue either another CR or pass an appropriations package. However, a CR is not effective lawmaking, and it often harms health programs, especially in this inflation environment where the value of dollars from the past fiscal year does not really hold over. The fiscal year starts October 1st, so the appropriations negotiations typically take place over the spring and summer. The executive branch typically kicks off that process by issuing the president's budget request to Congress. In most years, that's issued in early February, which gives appropriators on the Hill time to draft and negotiate the bills through the summer. The president's budget is a non-binding document, but it's a critical moment in the spending process because it serves as an opportunity for the administration to signal its policy and spending priorities. Importantly, it also serves as a starting point for congressional negotiations, especially if the majority party in Congress is aligned with the president, in which case the budget is likely to be used as the foundation for that year's spending bills. And we're likely seeing that this fiscal year with the first real Biden budget. The White House Office of Management and Budget coordinates the federal budget process and works with the Office of the President and federal agencies to develop the spending proposal for the upcoming fiscal year. Once that budget request is released, top appropriators from the House and Senate, known as the Four Corners, work to land on an agreement for top-line spending numbers, effectively capping total spending for the upcoming fiscal year. With that top-line spending agreement in place, the House and Senate develop budget resolutions that instruct the appropriations committees and its 12 subcommittees to draft their spending bills within the parameters of that top-line agreement. The subcommittees, each with its own spending jurisdiction, draft spending bills which are marked up and voted on in committee and then compiled into a consolidated spending package. Once the House and Senate finish their respective bills, Congress meets jointly to finalize that consolidated appropriations package, which is then signed into law by the president. In fiscal year 2022, the one that just passed, Congress struggled to reach a compromise on a spending package. Partisan disagreements and Republican obstruction resulted in an extraordinarily long negotiation cycle, and Congress had to pass a string of continuing resolutions to keep the government afloat. I think it was around 3. This was due in part from a delayed transfer of power after the 2020 election, which really hampered OMB's ability to get a budget proposal in place. Following that, Democrats tried to pass the Build Back Better Act through the budget reconciliation process, which is a lengthy procedure that allows the majority party to bypass the filibuster and pass certain spending provisions along party lines with a simple majority. However, in the evenly split Senate, that meant that Democrats had to achieve consensus within the party, which was no small task. That effort stalled and dragged on for months, further delaying the appropriations process. The finalized package did not clear Congress until March 16th of this year. There are 2 funding lines that HAP lobbies in support of on the Hill. They are both included in the Labor, Health and Human Services, Education, and Related Agencies Appropriations Subcommittee, or LHHS. The first is for the Viral Hepatitis Prevention Program at the Division of Viral Hepatitis within the CDC's National Center, that NCHHSTP. DVH coordinates the delivery of core hepatitis services like testing, prevention and vaccination, provider education and outreach, and disease surveillance across all jurisdictions. DVH issues grant making and facilitates policy change and disease surveillance in order to establish key hepatitis prevention targets and coordinates the federal response to the viral hepatitis epidemic. In FY22, the Hepatitis Prevention Program received only a nominal plus-up of $1.5 million for a total of $41 million. Unfortunately, that is standard order for hepatitis funding, which often is flat funded or receives a nominal increase, typically not above $5 million. The second funding line we advocate for is another program within that national center, the Infectious Disease and the Opioid Epidemic Initiative. That program was authorized in 2019 when Congress appropriated $5 million in funding to respond to the dramatic increase in infectious diseases especially Hep B and Hep C, that occur through injection drug use. This funding line supports the National Harm Reduction Technical Assistance Center and aids jurisdictions with a high disease burden or overdose mortality rate to establish partnerships with community-based harm reduction providers. It's one of the most critical methods to address skyrocketing hepatitis rates because it addresses the key the key driver of hepatitis infections, which is injection drug use. And it also enables providers to transcend disease portfolios. By detecting and intervening on hepatitis outbreaks, health departments are more able to respond to the severity of the crisis. Without this funding line, the nation's public health system would be trying to treat its way out of the epidemic, which is costly both to people living with hepatitis and to the health system as a whole. Last year, that program was funded at $18 million, which is a $5 million plus up from FY 2021. Additionally, HAP advocates on the Hill for appropriators to include language that would lift the prohibition on the use of federal dollars to purchase syringes. This stigmatizing policy has been tucked into the yearly appropriations bill, preventing SSPs and community-based harm reduction providers from providing sterile injection equipment, which is one of the most effective ways to stop disease transmission. In addition to being bad public health, the prohibition requires scrappy SSPs to come up with other funding to purchase supplies, which is one of the top cost prohibitive barriers that SSPs face in trying to become operational and sustainable. This year's presidential budget request to Congress was delayed due to the drawn out spending negotiations in FY 2022 and was finally issued on March 28th of this year. The hepatitis community was thrilled to see that the Biden-Harris administration proposed a $13.5 million increase for viral hepatitis programs in the president's FY 2023 budget request to Congress. This type of substantial increase hasn't been seen from an administration in the past decade, and we're hopeful that the administration's strong show of support for an increase will be mirrored by Congress. Additionally, the budget includes strong language in support of achieving a viral elimination of hepatitis in the US and broadening hepatitis screening, testing, and vaccination efforts. HAP is advocating on the Hill to make sure that Congress includes that $13.5 million increase in the final spending package. We're hopeful that with the administration's blessing, Congress will finally have the backing to propose such an increase for an often overlooked program and have it stick through to the final package. Our legislative strategy includes scheduling Hill visits with every office on the LHHS subcommittees and eventually reaching out to the broader Appropriations Committee members. Additionally, we draft sign-on letters in support of our funding requests and circulate those letters to Appropriations staffers. This year, 59 organizations signed on to HAP's letter to Congress, including this group, and we're so grateful for your support. Additionally, thanks to partnerships that the hepatitis community has forged on the Hill, we leveraged the Hepatitis Caucus to circulate a Dear Colleague letter where fellow lawmakers endorse the community's hepatitis requests that are sponsored by the caucus leads. For this fiscal year, 34 representatives endorsed our ask, and the Senate version is still circulating. So what funding level requests are we taking to the Hill this year? For fiscal year 2023, we're asking for $140 million for the viral hepatitis prevention program. This number was agreed upon via consensus and is based on the dollar amount that the Division of Viral Hepatitis could immediately put to use to scale up hepatitis services and refine hepatitis infrastructures in select jurisdictions, as well as expanding workforce and capacity and bolstering jurisdictions' ability to develop elimination plans. Although DVH and hepatitis programs could certainly use more money, Congress and Republicans in particular would be loath to allocate a large increase in dollars and not have that money drawn down completely by the end of the fiscal year, saying that it's ineffective spending. Over and again, we are hearing from congressional staffers that although our ask is understandable, it's a tough sell for Congress. That's why we're working hard scheduling visits with as many appropriation staffers as possible to familiarize them with the full scope of need and to materialize an increase that locks in the president's proposed increase, but goes above and beyond that. It's important to note that as unpalatable as requesting a 341% increase in funding for hepatitis programs can seem to appropriation staffers, the full financial need is actually a lot higher. In 2016, a CDC professional judgment budget uh, determined that a comprehensive national viral hepatitis program would need closer to $316 million a year over 5 years to put the US on the path to eliminating HBV and HCV. However, viral hepatitis programs have been underfunded at 32 million per year in the past decade on average, which is nearly a 90% deficit from the required funding need. And for the infectious disease and the opioid epidemic program, we're supporting an ask of $150 million that is spearheaded by the Drug Policy Harm Reduction subgroup of the Justice Roundtable Coalition. An increase to this program would support greater provision of technical assistance and capacity building via the Harm Reduction Technical Assistance Center, and they would target funding to select jurisdictions that are at risk of or are experiencing hepatitis outbreaks or a high rate of overdose deaths. We're currently meeting with as many offices as possible, given that it's in the thick of approach season, and trying to socialize our asks before committee staffers start to draft their spending bills, which could happen in the coming weeks as soon as there's an agreement on top line spending numbers. Given last year's delayed appropriation cycle and the string of CRs and shutdown threats, and with the Ukraine crisis and midterm elections coming up, both parties have political incentives to move forward quickly with this year's spending bills and avoid last year's scenario. Democrats' legislative strategy has been hampered by lockstep Republican opposition and key internal defectors. Think Senators Joe Manchin of West Virginia and Kyrsten Sinema of Arizona, who have effectively blocked the Biden administration's social spending priorities. In light of that, Dems are now eager to notch some policy wins ahead of that midterm election. And this spending bill may be one of their last few feasible legislative vehicles that are available to do that. However, Republicans know that, and they're going to try to derail that timeline due to partisan opposition against quote unquote controversial policies like funding for syringes, coverage for abortion, and additional dollars to the COVID response. Republicans may also try to draw out the process until after the midterm elections, when they may have a better standing in negotiations, considering that they're expected to take the Senate and the House. However, top appropriators across both aisles have a vested interest in passing the FY 2023 appropriations bill on time, regardless of the overarching political narratives that may complicate timing. And based on what we've been hearing from staffers on the Hill, we're expecting a CR through the summer, through the early fall, and then a finalized appropriations package after the elections, but before the new Congress, so during that lame duck session. We're also fighting back against backlash for the Biden administration's support for harm reduction programs. You may have seen that over the past few months, Republicans have zeroed in on harm reduction funding, claiming that the Biden administration is enabling drug users and providing free crack pipes with federal dollars. This talking point seems to have resonated with the right-wing base, and some Republican senators are seeking to implement broader drug paraphernalia bans that would implicate even more harm reduction services than just syringes and safer smoking kits. This puts funding for the infectious disease and opioid epidemic under increased scrutiny, and unfortunately virtually guarantees that the prohibition on the use of federal funds to purchase syringes will not be lifted. So although we're seeing a lot of momentum and hope really for the hepatitis funding, we're seeing a lot of roadblocks and hopefully not too many steps backwards with the infectious disease and opioid program. Additionally, we're preparing to meet with the health staffers at OMB in advance of FY 2024 executive budget request to Congress, which would come next year. OMB typically locks in that budget request in the fall, so it's important to meet with them well ahead of the budget release to uplift our funding requests. HAT met with OMB around this time last year, and we believe that the conversation was instrumental in securing the proposed $13.5 million increase for viral hepatitis programs in FY 2023. So we're hoping to learn how that increase came to happen and how we can replicate it in FY 2024. Additionally, last year, HAT met with key officials at HHS and CDC to uplift the need for a greater focus on viral hepatitis and calls on the administration to make sure that funding justifications sent to OMB for that presidential budget request greater reflect the need of viral hepatitis programs. We met with the HHS Assistant Secretary for Health, Dr. Levine, and staff from the HHS Office of Infectious Disease and HIV/AIDS Policy, or OIDP. OIDP coordinates the National Viral Hepatitis Strategic Plan, which is a 5-year whole-of-government strategy for achieving viral elimination by 2030. The strategy lays out a roadmap for the federal government, health departments, community-based partners, and other stakeholders to scale up hepatitis services and set the nation on the path to achieving that viral elimination. The strategic plan will be accompanied by an implementation plan, which should be released in the coming months. The director of the National Center, Jonathan Merman, and Dr. Carolyn Wester, director of the CDC Division of Viral Hepatitis, also joined that call. So what's next in the hepatitis policy landscape? Apart from appropriations, there are other items in the hepatitis policy world that we're keeping our eye on. In addition to that pending implementation plan, the 2020 Viral Hepatitis Surveillance Report should be released in the coming weeks or perhaps months. This federal snapshot of epidemiological data provides a critical checkpoint for the nation's progress on preventing new infections of hepatitis and linking people to treatment and cures. The 2019 report showed troubling signs for the nation's ability to actually eliminate viral hepatitis by 2030. According to the report, the number of new HCV cases increased by 93% from calendar years 2013 to 2018, with new cases in 2019 significantly exceeding the CDC's targeted cap required to set the nation on the path to achieving viral elimination. Additionally, the rate of acute HBV infections increased by 11% from 2014 to 2018, despite the availability of preventive vaccines. And so we're really losing ground despite having the tools. And our data suggests that up to 70% of new HCV infections and 36% of new Hep B infections are due to injection drug use, which really elevates the critical need to direct targeted resources towards jurisdictions that are at risk of or are currently experiencing hepatitis outbreaks among people who inject drugs. And that's why supporting both the funding lines at the Division of Viral Hepatitis and the Infectious Disease and Opioids program is so important. We're waiting with a bated breath for that new report, which will unfortunately likely demonstrate even wider gaps in prevention and treatment targets as a result of disruptions to health service delivery caused by the COVID-19 pandemic. Additionally, the CDC is currently accepting public comment on updated screening and testing guidelines for hepatitis B. They're proposing screening at least once in a lifetime for persons 18 years of age and older using a 3-test panel. They also updated recommendations to expand existing risk-based testing recommendations for persons currently or formerly incarcerated, persons with a history of sexually transmitted infections, and persons with a history of hepatitis C virus infection. These recommendations align with the shifting epidemiology of HBV transmission and will support efforts to improve stalled progress on preventing new hepatitis B infections. They also complement the CDC's recent adoption of universal adult vaccination against hepatitis B for adults ages 19 to 59, which was voted unanimously by ACIP last fall and adopted by the CDC director this spring. Together, the screening and testing updates with the vaccination updates will boost hepatitis providers' capacity to inoculate more people against a lifelong HBV infection. However, more funding, as always, will be necessary to effectively implement these changes, since they will require patient and provider education, as well as funding for vaccine administration and serologic testing. In conclusion, I wanted to highlight 3 key takeaways. The first is that things are actually kind of looking up for hepatitis funding, and they haven't in a long time. The recent policy wins, such as the National Viral Hepatitis Strategic Plan and upcoming implementation plan that work towards viral elimination, the expanded hepatitis B guidelines, and the President's FY 2023 budget request to Congress that had a strong showing of support for an increase to hepatitis funding all create a solid justification and foundation for an increase to materialize in the coming fiscal year. The second is that affecting policy change often requires pulling every lever at our disposal. Our conversations with OMB last summer would not have been effective if we hadn't also met with health officials at CDC and HHS and elevated the funding needs for viral hepatitis programs there. And without a proposed increase from OMB, securing an increase on the Hill is that much harder of an ask. The last thing I would underscore is that notwithstanding all of the recent policy wins, our public health system is losing ground on the hepatitis epidemic. We have work to do to educate local elected officials, Congress, and the public on the severity of the hepatitis epidemic, and to underscore the intersections with injection drug use. At a time when public health is so polarized and politicized, we need to make it clear that funding for infectious disease programs is non-negotiable, and that public health approaches to injection drug use is sound public health.